Okay,
And
starting
I would
with,
like to welcome Dr. Goldstein and Daniela Contreras with Psychiatry of the Palm Beaches to talk to us about tardive dyskinesia.
so thank you everyone for joining us. We're happy to be here. So our conversation, our lecture will be on tardive dyskinesia. We'll probably refer to it as TD from here on out. And the focus really will be understanding what it is, recognizing it, and a bit about the treatment. It's a syndrome or a side effect really that affects people, and we'll get into all of that. But it affects patients as well as caregivers. So let's see. So really quick, just disclosures. We have no conflicts of interest, nothing to disclose, no financial relationships with any of the medications or companies that'll be mentioned. There will be some medications mentioned by name, primarily two that are really the only FDA approved treatments for TD, but we'll get into that later. So the agenda is identifying or defining what TD is, why it happens, how to recognize it, and how to treat it. And by the end of this lecture, the hope is that you'll know what tardive dyskinesia is, understand what it feels like and the impact for patients, identifying the signs and symptoms in yourself, a loved one, or a patient if you are a caregiver or a provider. You'll learn about who's at risk, why it happens, a bit about the AIMS exam, which is a screening tool, understand and identify the FDA approved treatments for it, and also, and potentially most importantly, how to start a conversation with the healthcare provider about it, whether it's advocating for yourself, a loved one, or your clients. And so, why this topic matters. It is often very underrecognized and underdiagnosed. We have statistics later, but it's about, thought of as 60% of people that have it are undiagnosed, which is a large percentage. The access to treatment, unfortunately, is unequal, like a lot of the case, in our field and other areas of medicine. That's because of insurance barriers, high copay, and also limited awareness. There are a lot of assistant programs, and the other thing is just spreading the knowledge and awareness because a lot of times, whether it's income, education, access to care, people just aren't aware of TD or of the fact that there are treatments available. Um, and if nothing else, we hope you take away that recognition and advocacy can change outcomes, can change lives. So it's very important. All right, I'm going to hand it over to Daniela.
Hi, everyone. My name is Daniela Contreras. I'm a PA. I've been in the field about 3 years. Very happy to be here. We're going to go over right now what is tardive dyskinesia. Just breaking it down, the name tardive comes from Latin, means delayed or late, and dyskinesia is difficulty with the dys and movement kinesia. So altogether is that it's a side effect that appears delayed from could be months to years, and it causes people to have these movements that are unwanted essentially or uncontrollable. So some things to know, it's not the patient's fault and not anything they could have done or prevented it. It's not a signal that mental illness is getting worse, and it is treatable. So if we do identify it in our patients, it's something to tell them about because they may have been noticing it on their own. And then they can also get help because a lot of people feel shame or some stigma attached to it. It is mostly affecting the face, the tongue, some truncal and like other muscles can be affected too, but these are how we communicate. So having someone like who's constantly chewing or pushing out their tongue can cause a lot of like shame because others may think they're on like drugs or have some other issues going on. Here, like we mentioned, the person is not choosing to make these movements. Stress usually worsens it. And the face and mouth, it can look like pursing, chewing, grimacing, blinking, sometimes confused with people having dentures. So you may want to ask your clients if they have dentures in. And the limb in the body can come up as swaying or rocking, ankles rotating, shoulders up and down. We'll show some videos even later so you can get a good picture of what it looks like. So how Sabina mentioned, it's often missed, and about 25% of people on long-term antipsychotics develop this. And like I mentioned before, it does have an impact on their self-esteem, confidence, and how they choose to interact with others. Because some people have to stop working or choose to stop working because of it if they didn't know that, there's treatment available.
Okay, so why does it happen? Primarily, or really only, it is caused by medication side effects. Now, the most common causes are antipsychotics. And I'm not sure, exactly who's on the call, so I'm not sure how familiar everyone is with the various medications. But, sort of general overview, their antipsychotics are typically broken down into what we call first generation and second generation. First generation are the older meds. Um, and they are more likely to cause TD. The newer meds are less likely, in part because as they were developed, scientists tried to minimize side effects to the extent that they can. But the second generation medications still can cause this. And other types of medications that affect dopamine can also cause this. So there are some GI, especially anti-nausea medications, like Reglan, for instance, is a very common one. It's probably the most common cause of TD outside of antipsychotics. There are some antidepressants that can cause it, the anti-nausea meds I mentioned, anti-seizure meds, such as Depakote, and some anti-vertigo medications. Now, the issue is that patients who are on these meds, and I'll say especially the antipsychotics, need them. This isn't, oh, well, let's just not prescribe because then they won't develop this. These medications can be life-saving and life-changing. And, we'll get into obviously how to manage it and what to look out for, but it is not a reason to, as devastating and difficult as TD can be, it's not a reason to not use medications that are needed. So, again, just overview. The reason that these medications can cause TD is because they block dopamine receptors. And that's intentional, right? That's what we need. It can help control any sort of psychosis, hallucinations, um, and, blocking them or at least partially helps to limit those symptoms. However, when somebody's on these medications long term, and we're talking usually years, but it can happen sooner, the brain sort of creates more dopamine receptors, right? It's this sort of um, if you're supposed to have dopamine receptors and they're all blocked, eventually your brain's like, well, we need this, like it's not working, let's create more and hope that that works. So there is this upregulation and there's also this hypersensitivity, so that whenever dopamine is able to bind, there's an overreaction in a sense. And this can create these involuntary movements. So who's at risk? So theoretically, anybody on these medications I mentioned, especially long term. And just backing up a bit, I didn't mention that Reglan, for instance, that medication, it's not, if you take it once or twice here and there, it's not a concern. It's mostly if you're taking it regularly for 3 months or more. But anyone who's on these medications, especially people above the age of 55, women or people assigned female at birth, African American individuals. Like I said, if you're on the medication for a longer amount of time, higher doses, and also the first generation antipsychotics. So all of that, and somebody, let's just say, who has sort of all of these risk factors, you definitely want to keep an eye out. Whether that you're, a caregiver or a provider of some kind, you want to have it sort of in the back of your mind that, hey, let's be on the lookout.
Okay, so how to recognize TD, either as family members, caregivers, providers, or patients. So the early warning signs are subtle. Usually no one really notices them, especially not the patients. It's more on other people who see them regularly to maybe tip them off. So blinking, especially if you're in telehealth for any providers, that's kind of going to be one of the first signs, increased blinking or grimacing. movements, maybe some small ones, tapping, pursing the lips, and then the swaying. What TD is not. So we do have a whole spectrum of movement disorders that can be caused by medications. So we're going to go through which ones or what other ones are there so we can kind of compare and contrast. So Parkinson's tremor is more rhythmic 2D, so two-dimensional up and down, versus TD would be three-dimensional movements. Tics or Tourette's will be brief and sudden. However, TDs could last all day. Akathisia is usually described as this inner restlessness. My patients will say like, oh, I just have to move. I can't sit still. I sit down. I want to stand up. And it's more of like internal. Anxiety, probably all familiar with it. Leg bouncing, biting our nails. And then dystonia is a contracture typically of a muscle. So patients will not be able to move or will be locked in a position, tends to be very painful, unpleasant. And then other syndromes such as Huntington's, which can perhaps start to present the same way, but then with more testing and history, we're able to rule that out.
I do want to add quickly that it's important for us on this side of things to be able to differentiate just because it guides treatment and it guides decision making. However, and we'll probably repeat this multiple times, if you notice anything, any movement, anything atypical, better to bring it up, and then we can help sort of differentiate and rule things in or out. But just so you know, this is sort of other things that may develop.
So here we have some videos. Press OK. So it's here. All right. Can everyone see okay? Okay, perfect. So this is what the lip smacking, puckering, or pursing may look like side to side. You'll want to ask your patients if your provider to open their mouth as well, because sometimes the tongue can be fasciculating, can moving back and forth. If you're ever with a patient, also ask them if they're chewing gum and make sure they're not so you can properly assess this movement. The blinking I find a little harder because some people are expressive and they do blink a lot or have dry eyes. But if it's all the time a little bit more than normal, please investigate or follow up. Here's what the upper torso looks like. Fingers. And then even we'll ask our patients to take off their shoes and socks so we can assess their toes. I had one patient tell me she wore a hole through her shoe from her big toe rubbing so often. Okay.
Oh yeah, this one. I guess we'll go back there for now.
Okay.
Okay. So we do have other videos here. For the sake of time, we won't watch all of them, but and again, if whether you are a loved one, caregiver, provider, sometimes, like Daniela said, it can be difficult to identify, especially if it does sort of develop slowly over time, and also if you are on this remote sort of telehealth platform. One little trick that I do sometimes for these patients is if I think somebody's blinking quite a bit, I'll try to match it, and if it feels like I'm blinking, uncomfortably or an uncomfortable amount, it kind of gives me a little, alert that hey, maybe this is something worth checking out more.
So this is how to screen for TD. It's important that we do this about every 6 to 12 months, even a baseline before starting antipsychotics. That way we know how it's progressing over time. It's scored from 0 to 4, 0 meaning no movements, up to 4 being severe. It is a little subjective, so you may want to watch some videos, check with another provider and compare results. And this is very important to have on patient's chart if you want to get the best chances of getting the medications covered as well.
So, again, like Daniela said, it is subjective, but if you are the main provider, let's say, or if you say, a patient comes to us, as long as we are the ones seeing them, hopefully our subjective, skew will be the same. So it'll help guide whether there's improvement, worsening. So even that alone is helpful, and something for you to know. The number, while it is important, it's not as important as the trend. So if you see it in your chart or a loved one's chart, just something to think about.
Okay, so this we included for patients and caregivers how to ask about it. If you want to, I think these slides will be shared later, but copy them. It helps to find some verbiage for you to include in the interview, and even for like clinicians to just subtly include it. It can be a little awkward to mention it because no one wants to be called out on something abnormal, but it is very important for us as providers to mention it and be aware and let the patient decide whether they want treatment or not.
So, yeah, it can be uncomfortable to bring up, let's say, to us, right? There are people who say, I don't want to tell, the doctor what to do, um, or even to bring up to a patient, let's say, whether you are a loved one bringing it up to your family member, or if you are a therapist or another provider, not to upset them, but at the same time, it's important to say, hey, I've noticed this, are you aware of this? Or, has this been going on for a while? And then to bring it up to us. I promise you that there's no, you're not accusing, you're not telling us what to do, you're helping, right? You're partnering with us and advocating, and that's always important. So how to treat it? So it is now treatable. In the past, it wasn't, and this is only a recent development, less than 10 years. In the past, the hope was, we could try to minimize progression by reducing the medications, let's say the antipsychotics, which often isn't possible and certainly wasn't. Like I said, these are life-saving, life-changing medications. And they're used in people primarily with severe mental illness, whether that is schizophrenia, bipolar disorder, depression, especially severe depression. And so they're necessary. But starting in 2017, the first medication, and we have two, were approved, FDA approved for TD. They essentially inhibit VMAT2, which helps sort of move dopamine through cells, through the synapses. So in doing that, it helps sort of modulate the way dopamine is used and released. So 50% of people achieve symptom reduction, a significant symptom reduction. We have a video or two we'll get to showing you that after it's usually about 6 weeks that people see a result. And this allows, using one of these medications allows patients to stay on the necessary medications and the necessary doses that they need for their symptoms, for their illness. So, the hope is that people who hopefully are stable on their medication regimen remain that way. And this just helps mitigate those side effects. So those two medications, Ingrezza and Austedo, they're similar, very similar. They're both once daily. Slight differences in terms of dosing and the titration, so getting up to a certain dose. Ingrezza has a sprinkle formulation as well, which is important, especially for some of our patients with TD who have a lot of orofacial movements, and even eating can be tough. So swallowing can be tough. So it's very helpful. For both of them, the most common side effect is somnolence. So feeling tired, sleepy. A lot of times with our meds, and maybe some of you know this, meds that have a side effect of somnolence may also have the opposite, a side effect of insomnia. But both, like I said, very similar. There is if you Google this or, use it, and you might see that there is a warning about suicidality. So studies did show that there might be an increase in suicidal thoughts when using these meds, but that's primarily in patients with Huntington's disease. Now, without going too much into that disease, a key unfortunately, a key part of that disease is developing depression, a severe depression. So it's likely that that's more of the disease process than the medications. Now, in clinical trials in patients with TD, these meds did not really show a clear increase in suicidal thoughts, but there is a warning about it, and so it's important for you all to be aware. So how well do these work? Like I said, there are at least half of patients who are on it feel and see a large reduction in symptoms. About a third of patients who are on it have, at least half of their symptoms improved, which is enormous. That's really a life-changing percentage. And then when thinking about older adults, which again is a patient population that's at a higher risk, a large percentage of them saw a meaningful response at almost a year out. So again, very, very promising. Um, we do have a video. Is it this one? So we have two, they're pretty brief, but showing you sort of where patients started and how they progressed on the treatment. So here's one.
The hyperextension and twisting movements of her trunk, neck, and back lead to postural instability.
Okay, so this is 6 weeks after beginning the treatment.
While seated, you see reduced truncal pulling with more postural control.
And then after 48 weeks.
Upon standing, there is significant reduction in dystonic movements, resulting in sustained postural stability.
It's a drastic improvement.
Though slight arching movements of her trunk are present, she is able to sit upright. In the face, dyskinesia of the lips and mouth appears reduced.
Just to compare from the baseline.
This woman with bipolar disorder has generalized tardive dyskinesia, primarily causing dystonic, hyperextending, and twisting.
You can see over time how she went from maybe being immobilized, unable to hold conversation, eat, engage in life, to yes, the movements are still there, but drastically reduced, and she's able to, live her life and do what she needs to do, despite having this disorder.
And there's one, actually, if we just, to see what it looks like. Oops, how do I get back to that?
Get rid of this.
This is why I need Daniela.
Here, or the slides?
Yeah, this one.
Okay.
So we scroll down. There's another just to see what it looks like in somebody else. So this is a baseline.
At baseline, this patient has abnormal body movements in several areas, including finger flicking and piano playing movements, head nodding, lip protrusion and pursing, and eyebrow raising. His total AIM score is 12.
And this is after 6 weeks, I believe.
And you can see lip pursing and head nodding, which is more clearly visible on the close-up view.
Oh, I think it didn't start at the beginning. Let's see if we can.
I think it did.
All right. So definite improvement in general. And again, I mean, when TD, can impact every aspect of somebody's life, they by choice can withdraw socially. And also because it can affect eating and even caring for themselves, getting dressed, depending on how severe. This impacts caregivers quite a bit. And there are studies that show that caregivers end up suffering as well. Sometimes they have to socially withdraw because of how much, time they're spending helping caring for their loved ones. And also, they get less time to spend on themselves and kind of do whatever else, needs to be done. And I know it is an act of love, but this can help, all involved.
And if we think back on that last gentleman whose video we showed, I sometimes even think about homeless people that I've seen, while driving around South Florida, making these sort of movements, and previously, and maybe even commonly thought, oh, they might be on drugs or they're tweaking, something's not right. And unfortunately, our homeless population does coincide with high mental illness rates. So it could be that they're going through this and undiagnosed.
And that is a great segue actually into getting access to treatment. So both of these medications, both of these companies offer financial help. They have patient assistant programs. They vary a bit in what they offer, but it's important to know and advocate for yourself or your loved one, but also bring it up to us, any clinician. And hopefully we're bringing it up ourselves, but to know that there are options out there. And this is just some other information. So there is a doctor discussion guide, as well for patients and families. And for providers, there is an AIMS training. There is other just guidelines on how to treat and how to go about screening.
In general, like we've discussed, to not stop the medication, it can worsen TD symptoms and our psychiatric symptoms. For the providers, don't use Cogentin. It's another popular older med, but it's used for something else completely. Consider dose change or medication change if it is safe or appropriate for your patient, or if it is a more severe schizoaffective, schizophrenic case, consider clozapine. It does have the lowest risk for TD of the first-gen antipsychotics.
So just, some main key things to remember. TD is real, it's diagnosable, it's treatable. It is not the patient's fault, as we said. It's not a sign of worsening mental illness. It is not also a sign of substance use. It's not a sign that patients are not taking their medications. The most important thing to do is speak up. Speak up to your providers, to family members, to patients. It can be difficult to kind of make that step of speaking up and advocating, but it's the most important thing. And sometimes that means, again, speaking up to the patient and saying, hey, I'm noticing this. Sometimes patients are not aware, and that's a key thing as well about TD, especially at the beginning. Some people subjectively, they just don't notice that they're doing it. So bringing it up, saying, hey, are you aware? I'm seeing this, and not in a judgmental way, of course, or a critical way, but there's something we can do about this. Let's take that step. You can ask for the AIMS exam if you're on an antipsychotic medication, or like we mentioned, even other medications, the antidepressants, some mood stabilizers or anti-seizure meds. Even if you're on a medication from a different, field of medicine or a different provider, if you are experiencing any of these symptoms, still bring it up. You can bring it up to us. We'll go through the medication regimen that you're on in general and kind of go from there. Remember that there are treatments. They are available. They are accessible. It's just about taking that action to get them.
Jumping through the insurance hoops.
Yes, unfortunately, but I imagine none of us are naive to that, unfortunately. So, and then the last, key thing is the medications, the psychiatric medications absolutely do not need to be stopped. The dose does not necessarily need to be reduced, or the medication does not need to be changed. They can be depending on the situation, but they do not need to be stopped. You do not have to sacrifice stability and symptom improvement because of TD. So here are some resources. Of course, NAMI is always a great resource. Like I said, there are the AIMS trainings for anybody interested. And you don't have to be a clinician or a provider to take a look at it. Familiarizing yourself will help you know, hey, that my loved one or myself, I do have some of these symptoms. So kind of might give you that extra motivation or drive to bring it up to us and get it checked out. And here are there are other links as well.
And that concludes our slide deck.
So we did breeze through it a bit. So I imagine, there might be questions. We're happy to answer.
Maybe I'll go to